So I was asked to speak about the future of healthcare in 5 years and 10 years from now, and the way digitalization might affect healthcare. I will try to speak to my experience at Mayo Clinic and other hospitals in the United States and in other countries. So I think a common context is the aging of the population. This is a very interesting slide, I think, that comes from the World Health Organization that describes the percentage of population over age 65 and the percent of GDP spent on healthcare in various countries. And you see the two outlier countries, Japan, way to one side with a highly aged population, États-Unis with a not so aged population, but a large percentage of GDP spent on healthcare. Now, if you include not just healthcare, but social insurance, these numbers change slightly. The US spends a little on social care and a lot on medical care, which is one of the problems that we face. Not just aging, but the method and mode by which we provide health to our populations. Are we providing health care or are we providing medical care? In the US, there's more emphasis on medical care and less on social support. A second problem that is persistent, I think, in every country that I've visited is the small number of medical personnel. Doctors, nurses, medical techs. In the United States, the problem is nursing. I understand from speaking with Nico last night that the problem here is maybe fewer doctors than are needed. So it changes a little bit. But the aging population plus the absence of medical personnel is creating a problem. Not enough care for too many people. I think a third issue is technology is arriving in our space, which can do things like aid with administrative simplification, with the summary of medical documents, and facilitate diagnosis and treatment. And you just saw a little bit about that in Professor Renaud's comments. And then finally, people who are patients are also consumers. And they have an experience from other industries around digitalization, and they expect that now in healthcare. I can reserve a table in a busy restaurant. I can plan my vacation. I can buy things online. I can manage my bank account. Why can't I do the same things with healthcare? And we hear that from our consumers all the time. So, what are some of the challenges with digitization? I think there's at least 4. One, it's very expensive. The new technologies are emerging quickly and are very interesting. I just spent a week, 2 weeks ago, at a conference called Google Next, where Google was showing its new technologies. And they're really remarkable on the ability to apply AI to a wide range of problems with lots of sophistication. But they're not cheap, and they'll be difficult to implement. Second, the technologies are complicated. This will require technology teams that have new levels of sophistication and capacity compared to what we've had before. We now need data scientists. We need full stack engineers. We need a variety of capabilities that many hospitals have not had in the past. So they either need to hire these people or they need to work with consultants and vendors to receive this support. The third problem is integrating all these technologies depends on standards. Standardization of how we exchange data and agreements on how we will do that. on standardization of document types, of vocabularies, and APIs, which is the technical method by which things connect to each other. And when I was speaking last night with Sandrine and Isabel from the Department of Health, and understand that this is a challenge in France as well as the US. And then fourth, these technologies depend on changing the way we work. And if I could indicate one thing that I think is the most important, it's that. We can do many, many things with technologies. And the reasons why you can reserve a table in a busy restaurant but not get an appointment online is not a technology problem. It's an organization problem, an agreement on how we should work together. And then it also changes the way that people think about managing their health. If we want to improve health outside our clinics and hospitals, that means people need to think differently about their health and the way that they may be able to apply these technologies. So in digital, what are some of the opportunities? The first is around simplification, administrative simplification in lots of ways. These are 4 things that we're doing in our clinic and we're seeing in other hospitals in the US. Things like automatic responses to electronic communications. We've done a good job of making our app and our portal available to our patients. And so they want to communicate with their doctors. So I now have doctors who receive 100 or 200 messages a day that they need to respond to. And it's very difficult. Some of those messages are simple, like, may I have a refill of my medication? It's pretty easy for an AI system to see, is this patient eligible for a refill? And if they are, say yes, and send a message to the pharmacy allowing for a refill. We need to be careful about how we're using these, but there's tremendous potential in how they can be used. The second is summaries of medical documents, in particular for complicated patients with a large file. We have a demonstration in place right now that summarizes notes from surgery. Surgical notes can be long and complex, but the physician who cares for the patient after surgery may be only interested in 1 or 2 key things and not everything that happened in the surgery. So we're making it easy for our physicians. Reports related to quality reporting and regulatory reporting. These are really important, but they're expensive and require a lot of resources. If these new tools can produce quality reports easily, it allows staff to work on different issues. And then finally, this idea of ambient listening, where the machines listen in to a conversation between doctor and patient and produce a transcript, a description of what happened, a summary, and may also then lead to some recommended steps. So I've seen the demonstrations using real technologies where a pretend patient talks to a doctor about a pretend case, and the technology has been successful in summarizing that conversation and then looking at typical orders that a doctor will issue in those circumstances and suggesting it to the doctor. Would you like to order these additional tests? Would you like to order this procedure? Would you like to order this medication? And so on. It works well. The second opportunity is actually before I go that, I want to give an example of the simplification in these slides, which comes from virtual nursing. So when I first heard about virtual nursing, I didn't understand it. It didn't make any sense to me. Nurses work directly with patients. Well, it turns out that nurses are spending a very large amount of their time on administrative tasks. So, for example, what can be done around patient education, around supporting other nurses and teaching them, around monitoring patients for safety issues, supporting physicians as they do rounding from bed to bed to bed in a patient, to deal with admissions, and to deal with discharge. And this is a study done not in the US, but in another location around virtual nursing. And in 2 sites, they reported their results. One had about a 6% improvement in the communication of side effects of new medicine. So avoiding bad side effects for patients. About an 8% improvement in the ability of patients to understand how they manage their health, and so on. These improvements are important. Even 10% changes make a difference in improving patient outcomes and reducing the burden on staff. Other digital applications is to help people manage their own health in different ways by supplying new kinds of information. Professor Renaud talked about telesurveillance. We are using that significantly at Mayo Clinic, where we have patients with very significant illnesses and acuities at home. We can monitor, and in a virtual way, a screen will appear and a doctor and a nurse will do rounding with their patients during the day where the patient is at home. Now, note, one of the things that this does is transfer nursing duties from a nurse to a caregiver at home, which requires training and support for that caregiver at home, but it also addresses this issue of lack of nursing support. Digital can also be used for diagnosis and treatment. And for that, I want to skip forward a few slides here. This paper was in Nature Cardiology from some cardiologists at Mayo Clinic. And the study was to determine whether they could use surveillance devices to diagnose and treat common cardiology diseases. And they were able to do so. It's hard to read this slide. Ooh, it's especially hard to read this slide. But you can check the paper. This comes from that paper. The study looked at patients that were known to have atrial fibrillation and another control group of patients that were known not to have atrial fibrillation. The study looked at electrocardiograms of both patient groups, but only when their rhythm was normal. And the test was, can we distinguish between these two populations by looking at normal sinus rhythm? And it turns out that they can, with a high level of sensitivity and specificity. This is an important outcome. So it means that a patient wearing a watch with a consumer-grade electrocardiogram measurement, we can determine if that patient has atrial fibrillation or not. And now we're extending that into monitoring and diagnosis of additional heart disease like hypertrophic cardiomyopathy, which is a difficult disease to identify, but when it occurs, it can be fatal in an instant way. So some interesting ways that these technologies are being used today in treatment. And then the second example that I would give is this is the process that we're using to try to bring AI into treatment. This distinguishes between two workflows. One at the top is the common workflow we have today, where a physician takes raw data and from that they produce a lot of outcome and then they communicate that with the patient. The new model interposes an algorithm to assist the physician with their review and with output. In the future, we hope to also use AI to produce that output that goes to a consuming physician. But today we're focusing on the algorithm here. Here's an example from a multi-specialty evaluation, same kind of workflow. I'm happy to describe this in more detail, but this is where physicians working together are providing aid to either a patient or to another physician who's taking care of that patient. So to back up and conclude, in addition to this diagnosis and treatment, there's also opportunities to use these tools for analytics. Descriptive analytics, what's happening today. Predictive analytics, what's likely to happen tomorrow. We're using tools, for example, to do surveillance across all of our hospitals to identify patients who are candidates for palliative care. Prior to these technologies, we would not see patients who were decompensating quickly and needed palliative care. Today, we are now identifying those patients more commonly so that patients can be transferred into the right kind of care, usually for end-of-life care in some new ways. And then finally, there's ways to use analytics in a prescriptive way to tell us what we ought to do, not just what is happening and what is likely to happen. Okay. Thank you again for allowing me to speak in English. You really didn't want to listen to my French any longer. But I look forward to any questions you might have.
Thanks, Cris. Thank you very much, Cris. If you want to ask something, des questions, you can do it in French. I guess Cris understands pretty well. Yes. Oui.
You talked about remote monitoring of patients at risk, like cardiac patients. Do you see remote monitoring progressing and becoming the norm in the future for various pathologies?
Yes, we do. We used hospital at home very successfully during COVID, and we're able to keep something like 120 patients at home rather than being admitted. And these were patients with fairly significant COVID, and the results were the same or better in terms of outcomes for those patients. So today we have what we call a command center in our hospital in Florida. And they treat probably 40 to 50 patients at any given time. We want to expand this to our other locations as well. So we see two opportunities. One is to avoid hospitalization, and the other is to shorten hospitalization. I have an example. Unfortunately, my file was too big, but I have a little video that talks about a patient with acute kidney injury who would normally be in the hospital for a week, but after 2 days was sent home. I was surprised at the level of acuity of the patients that we're treating. So I think we'll see it as an increasing norm. Our hospitals are all being constructed to just take care of critical care patients, assuming that other patients will be at home.
Another question there. Hop, can take the mic.
Guillaume Simon, I'm the CEO of MindPulse. We do expert cognitive assessment. So my question is linked to that. How do you see in the US or in your hospital, what is the target or the vision of the future in mental care, where things are currently often very intuitive, and so that there is of course a move, and you talked about Google around connecting objects and also listening, interpreting language and so on. So how do you see the future or the directions in that area?
Thank you. So let me talk about before generative AI and after generative AI. You know, in November, OpenAI released ChatGPT and the world changed in many ways. Lots of people are focused on those technologies. Before ChatGPT, we were using many different machine learning techniques, mainly neural nets, to be able to identify opportunities. So we have today, for instance, something like 45, 46 algorithms that run within our electronic health record. An example would be we have a machine that scans chest x-rays that looks for particular issues to be addressed, and that brings it to the attention of the radiologist. It doesn't conclude that there's a lesion in a lung, but it suggests that there may be one there to improve the ability of radiologists to identify that. I gave the example of our surveillance for things like palliative care. We have indicators in place for detection of sepsis, other kinds of things. In our collaboration with Google, we've developed some methods for contouring tumors for purposes of radiation therapy. So the process of contouring, which is to identify the tumors and from that develop a treatment plan, that process can take a physician and a dosimetrist and maybe a physicist in some instances. It'll take them hours, maybe a day to do that plan. These algorithms now do it in just a few minutes, and the algorithms provide multiple pathways for the radiation to be delivered. Maybe, and we focus on head and neck cancers first. Maybe the standard method is to bring the beam this way, but the algorithm might suggest that if the beam comes this way, it would produce less damage to the patient as the radiation moves through the body. So those are some examples of what's happening now. After generative AI, the opportunities now exist around dialogue and communication in some really profound ways. The technologies that I have seen that are the most interesting are, number one, the ones that reduce hallucination, where AI has been making things up. That problem is getting addressed. Number two, the technologies are now becoming conversational, so that a patient or a doctor can ask a question and get a response. If that answer is not good enough, you can ask the next question, or you can ask a question to make things clear. And it sounds really simple, but the idea of allowing someone to have a real conversation where the machine remembers context is very different. It's remarkable. So I think these technologies will be mainstream in the next 2 to 3 years. I've seen what our electronic health record vendor, Epic, is doing around integrating these algorithms, and it's really impressive. I think it will change care.
Any other question? Yes. Here. And there.
Merci. Mathieu, designer, thank you for everything. We talked about simplifying, about digitaling supports. What will happen for the long term for young doctors? You thought about the education. They are supposed to be the next guardrails of this new technology. What will happen in 20 years when they will support on this and maybe have, as we need more doctors, there'll be probably more doctors coming more easily because of those technology. Who would be the guardrails of our medical support?
Thank you for that really important question. So all the methods that we've used today, and the only methods we have planned, occurs where a machine helps or makes a recommendation but doesn't make a decision, where the doctor makes a decision. So we like to use the phrase augmented intelligence rather than artificial intelligence, meaning the machine and the person working together. There's a really great article by an economist named Erik Brynjolfsson, and maybe with Nina I will make my slides available to you all, and I'll send a link to the article. And he makes an argument, not just with healthcare, but across all industries, that we will make a mistake if we look at how these technologies can replace what humans do, because that assumes we will continue to do things the same way. And he makes the point through history that the most important technologies have changed the nature of the work, so that it's the relationship between people and technology that needs to change, not just technology applied to that thing. And you can think in your head, imagine what industries have changed over centuries where technologies has changed the nature of the work. So specifically in healthcare, yes, these tools are being used now for education by creating simulation tools, for example, and providing other support. I have heard that our residents were really excited about ChatGPT, and they would ask questions so that they would feel more confident in answering a patient question or a doctor's question. That was dangerous. We have banned that use. We don't want our residents to be depending on a tool to think for them. We want the residents to think for themselves, right? So I think if this technology evolves as we think it will, I think it will change the nature of work. So for example, I think about technology as a technologist. These tools, for instance, now can generate computer code from a question. So I can say to a machine, please write me Python code that looks at this database and compares this population to this population for these reasons. And I don't have to know any Python code, it just happens. I think the equivalent of that will come to medicine, where computer programmers today write code. In the future, programmers will run coding machines. That's my view.
I'm sorry, but when you ask ChatGPT to write Python code,
Yep.
it writes bad code. That I'm afraid it will happen in the healthcare field also.
I completely agree with you. ChatGPT is really poor at it. The examples that I saw that were impressive were Microsoft has a set of tools that they call Copilot. Google has a set of tools called Duet, and they're substantially better. These tools are getting better and better all the time. Are they ready today for medical care? No, absolutely not. They're not. But they will continue to evolve, and I think they will change the nature of work. And I think that physicians will learn how to work with the tools. They won't be substituted by the tools. You know, 10 years ago, it was said that computers will replace radiologists. They won't. Ma copine est en radiologie, and I sit with her sometimes. She spends 30 seconds looking for a lesion. Then she spends 5 to 10 minutes doing a report and comparing to prior studies. And machines can't do that today. So,
why not?
We'll see.
Another question? Eric, there?
Being very brief, I'm a member of the National French Committee of Digital Ethics, and you mentioned ambient listening. How do you see the ethical dimension of this issue?
So the ethical, there's multiple ethical problems. One is the machine's listening. Will that be a private conversation? That's a big issue for us. So in 2019, we created an alliance with Google to do this work. And today, we've built something that we call Mayo Clinic Cloud, which has close to 40 petabytes of data in it. That's 40,000 terabytes or 40 million gigabytes of data. It's huge. And our agreement with them has strong legal limitations and then controls to make sure that Google and we are following our agreement. So Google has no ability to look at our data. It's locked in a particular enclave where they don't have rights to see that data. We asked for an opportunity. I'm sorry, I won't make this complicated. In the end, we had an agreement with Google that they will have auditors identify whether anyone accessed our data. And we will receive that auditor's report. So we know now for almost 4 years that no Google engineer has ever looked at any Mayo Clinic data in Mayo Clinic Cloud. So that's important to us. So we believe that any technology that we implement must have these legal agreements around privacy to avoid the risk that patient data will be used in some other way. You know, am I worried that some cyber criminal is going to hack Google or Microsoft? Yes. But I'm more worried that they're going to hack my data center. So I feel much safer with that data being in that environment. So I think that addresses many of the privacy ethical issues. Then there's other ethical issues like, do the machines listen accurately? Do the machines have bias? Do the machines listen to women and men differently? Do they listen differently when someone speaks with an accent, for example, in an American clinic? We don't know. So we're not using these tools today. We're just observing the demonstrations. But the technologies are getting 10 times better every year. We're at that point in the improvement curve. So I fully expect that these tools will be able to listen just as well as a human scribe within 2 years. And that's kind of remarkable.
Thank you, Cris.
I don't know if I answered your question, but that's how we're thinking about it.
Last question.
Sorry.
Thanks. I'd like to know how is your hospital organized to support innovation? Are ideas only coming from doctors or only coming from the direction, or is did you organize your structure more widely to be able to support the innovation?
Yes, in many ways. So we have a group in Mayo Clinic that just focuses on digitalization. So they imagine what products patients might want. They don't build them, my group builds them. We have a separate group that we're developing now to create solutions just for generative AI. And that group will be data analysts and others that will imagine what the products will be, and then my team will build them, or Google will build them, or some other partner will build them. In general, Mayo Clinic is doctor-led. So I am accountable to our Chief Medical Information Officer, and he directs me. And we make decisions with consensus and so on. The one thing we're worried about is our consensus decision-making process is very good, it's fair, it includes everyone, and when we make a decision, we don't change our minds. So all that's good, but it doesn't go fast enough.
Thanks for the
So that will be our challenge.
So we have some similarities, I guess. Thank you very much, Cris, for your intervention.